All right, today we're going to dive into a medical case that's basically a real-life detective story. It's a fascinating look at how a really scary, life-threatening symptom in one part of the body can just be the shadow of a totally silent problem hiding somewhere else. Our story kicks off in the emergency room with a symptom that would terrify just about anyone. We're not talking a little streak of blood here. We're talking a sudden, massive, and alarming cough of bright red blood. The patient who shows up is clearly in bad shape. You can just see it. They're exhausted, they look malnourished, and they're really not in a condition to give a detailed medical history. All the ER team knows for sure is that this person's lungs are bleeding, and they have to figure out why, like, right now. So the first move is a chest x-ray, and boom. The very first clue is a huge one. Staring right back at them from the film is a big cavitary lesion. And what that means, essentially, is that a hole has literally been carved out of the patient's lung tissue. This discovery immediately frames the whole investigation. It raises the central question of this entire mystery. What on earth is so destructive that it can create a cavity inside a living, breathing lung? So, the team starts by lining up the usual suspects. This list right here, this is pretty much the standard playbook when you see a hole in the lung. Could it be a classic like tuberculosis? Maybe a nasty bacterial abscess? Or a fungus? Or it could even be something more sinister like a type of cancer that's outgrown its blood supply and died in the middle. The hunt is on. Now, while all those initial tests are running, a really sharp doctor decides to do a deep dive with a physical exam, looking for clues beyond that X-ray. Sometimes the body whispers its secrets in very subtle ways. And yep, the clues are definitely there if you look closely. The patient is pale, which makes you think they've lost a lot of blood. There are these tiny little lines under the fingernails, we call them splinter hemorrhages, which are a classic sign that tiny clots from an infection might be traveling through the bloodstream. But the biggest clue? The doctor hears a faint heart murmur. That's the sound of turbulent blood flow that points to a problem with a heart valve. All of these signs together are practically screaming that this is not just a lung problem. The lab work comes back, and it definitely confirms there's some serious inflammation going on system-wide. But the absolute game changer is the CT scan. Look at the pattern here. It's not just one big cavity. It's actually multiple smaller ones, and they're scattered around the edges of the lungs. Now, that is not how a typical lung infection presents itself. And this right here is the team's new leading theory. This pattern is a textbook case of something called septic emboli. Basically, small infected clots are being fired off from somewhere else in the body, traveling through the blood and getting stuck in the lungs. You see, the lung isn't the source of the fire. It's just where all the embers are landing. Okay, so the team feels confident now. They're on the right track. The source has got to be an infection on the right side of the heart, a condition we call endocarditis. But just when they think they have it all figured out, the investigation hits a massive brick wall. See, to prove there's an infection in the bloodstream, you have to actually grow the bacteria from the patient's blood. It's the gold standard. So they send multiple samples of blood, samples of sputum from the lungs, and the results come back negative. Every single one of them. This creates a huge paradox, right? The CT scan is yelling systemic infection at the top of its lungs, but the lab's most definitive test says there's nothing there. How can both of those things possibly be true? But the lead physician doesn't waver. They're relying on a crucial piece of clinical wisdom. And this is a really key takeaway. A negative test doesn't automatically cancel out strong clinical evidence. Some bacteria are just incredibly fussy and hard to grow in the lab. You have to keep going, guided by what the patient's body is telling you. So the focus snaps right back to the main suspect, the heart. If the problem is really in there, they just need a better way to see it. First, they do a standard ultrasound on the chest, a TTE. It shows nothing. But the team doesn't give up. They move to a more invasive but way more sensitive test, a transesophageal echo. This is where the probe goes down the esophagus and gets a crystal clear picture of the heart from the inside. And bingo! There they are, small, hidden clumps of bacteria, what we call vegetations, clinging to the tricuspid valve on the right side of the heart. And with that, the diagnosis is confirmed. It's right-sided infective endocarditis. So let's break that down. The infection on the heart valve was causing these tiny infected clots to break off. They would then travel straight to the lungs, get lodged in the blood vessels, kill the tissue around them, and that's what formed those cavities.
So now they know what is happening. The big remaining question is who? Who is the microbial culprit responsible for all this? Well, it turns out the lab didn't give up on those initial blood cultures.
After waiting for days, long after a normal culture would have been thrown out, a single one of those bottles finally flags positive. Something is, at long last, growing.
And the culprit is a bacterium with a name that is, well, it's a real mouthful. Aggregatibacter actinomycetum comitans. This little guy is a member of a notorious crew of bacteria called the Hayseck group, and these Hayseck organisms are famous for two things: growing incredibly slowly and causing this exact type of culture-negative heart infection.
This bug is a true specialist. It's super hard to grow because it's capnophilic, meaning it needs extra carbon dioxide. Under the microscope, it forms these really unique star-shaped colonies. And it comes armed to the teeth with nasty toxins that let it kill immune cells and dig into tissues, which makes it perfectly designed for this kind of destructive infection. Okay, so now for the final piece of the puzzle. We know the what, we know the who, but how did this specific, kind of rare bacteria get into the patient's bloodstream to begin with? And the answer is actually surprisingly common. A dental x-ray reveals some severe, long-term dental infections. See, it turns out Aggregatibacteria is a totally normal resident of the human mouth. For most of us, it does absolutely nothing. But with poor oral hygiene and dental disease, it can become a serious problem. So this slide here just maps out the entire incredible chain of events. It all starts with a dental infection that allows the bacteria to slip into the bloodstream through inflamed gums. From there, they traveled through the body and found a perfect place to set up camp on the heart's tricuspid valve. They formed those vegetations, which then started breaking off and showering the lungs with septic emboli, carving out the very cavities that started this whole mystery. What an amazing case. It's such a powerful reminder of just how interconnected our bodies are. And it leaves you with a really fascinating question to think about. How often is the thing we see, that big, dramatic symptom, not the real disease at all, but just its distant, echoing shadow?